Next, we will hear from Dr. Edwin Chapman, an internal medicine and addiction medicine practitioner who has practiced in Washington, D.C. for over 45 years. He brings extensive experience to the conversation today, including as a founding member of the Leadership Council for Healthy Communities, where he works to bring integrated medical care to underserved communities and faith institutions. He has published research and testified before Congress to improve access to treatment of opioid use disorder. We're grateful he is with us today to share his perspective. Dr. Chapman?
Thank you so much, Kate. And you bring my slides up. Thank you. So we know that the opioid epidemic in the African American community has been around for decades, pretty much since the Vietnam era. And it was treated as a criminal justice problem. And it was well documented in this book by Michelle Alexander, in which she really showed that our patients were incarcerated treatment. So this has been viewed as a moral problem in the community, and it's been viewed as a moral problem by the medical community, by the media, by families, by government, so that in order to address this, we really have to take a different approach. And now that we know that it's a medical problem. When we look at that in comparison to what we're seeing now, that it's become more widespread in the rural and suburban areas, it's been documented as a disease. And we also know that as a disease, there's an association with anxiety, depression, and stress. And we can see from this study in JAMA that with the closure of automobile assembly plants, within 5 years, there was an 85% increase in opioid overdoses. So we can extrapolate that understanding and assume that alcohol is also impacted in the same way. So this is how drug use and self-medication is associated with economics. You can't separate the two. This is a paper that was just published by a group associated with the W. Montague Cobb Institute, National Medical Association Health Institute, really showing the relationship of the social determinants of health to the opioid epidemic. And I'm going to go into some detail later on. But this diagram really shows that association. And we have to look at it from not only a structural standpoint, but also from a genetic standpoint as well. So when we look at the components of this epidemic, we always think of physical pain, but we now have to think of emotional pain or psychic pain. And when we add that to genetics, we can pretty much come up with a risk pattern or so-called addiction risk. Now, we talked about the opioid epidemic in terms of pills in the suburbs and rural areas. But as I said, the Black opioid epidemic pretty much started with street drugs and heroin and transitioned to synthetics or fentanyl around 2014. You look at Washington, D.C., where I practice, I'm right in the heart of Washington, D.C. at the crossroads. And you can see that in 2015, our drug supply was 20% fentanyl or synthetics. But in 2021 and now 2022, we're seeing 96% fentanyl. Heroin has pretty much disappeared. This is how it impacts the rest of the country. This is an article that came out in September of last year showing that between 2018 and 2019, according to the HEAL study, that African Americans, the rate of overdoses and deaths in African Americans exceeded the general population. So now we know that with COVID, we're seeing a further increase in that separation. And this slide simply shows that 44% increase as opposed to 22% for the general population. And the reasons why are many. We now know that older African Americans, particularly those older than 65, are dying at 6 times the rate of white men. And in 2020, that rose to 7 times. We also know that there are disparities based on income inequality. So here in Washington, D.C., we have a marked disparity in income on the between the west side and the east side of the city, and I'll show you how that plays out. So just because a city has a wealth of medical information and medical schools does not necessarily convert into treatment. We know that substance abuse is common, but treatment is not. Only 1 out of 12, 8% of African Americans who overdose and die in treatment. We also know that the potency of the potential capacity for opioid treatment and mental health varies by race and ethnicity. So this slide simply shows Philadelphia on the left-hand side as an example of the decrease in heroin, and panel A, panel B, the increase in fentanyl, panel C, the disparity between white and black, and final panel really showing the marked increase in overdose deaths compared to homicides. We see this in 4 different states, including the District of Columbia, the separation between black and white in per capita deaths. The next panel simply shows in absolute numbers. And when you look at the circled areas on the right-hand side, shows the impact of COVID. And this simply shows the marked increase in overdose deaths among African-American men. This is from the Pew Trust that really illustrates the total cost of the opioid epidemic in terms of criminal activity, medical costs, as well as social costs because of job loss, et cetera, economic losses. We know that from a recent report from North Carolina, for instance, that naloxone, for every dollar spent on naloxone, saves $2,800. That's an astounding number. So when we look at the cycle of despair, we also need to look at the cycle of repair. And that, from our standpoint, involves the entire community. So how do we treat a person? How do we get a person engaged? And what we've learned from experience is that we have to have advocacy. And so we have to have legal advocacy, we have to have professional advocacy in order to get patients into treatment. And we also have to have massive education within our re-education within our communities. And we also have to deal with the social structural problems like homelessness, and the fact that patients often will not self-refer because of shame. So this was a panel that I participated in between 2019 and 2020 with the National Institutes of Health, really showing the relationship of treatment for opioid use disorder and infectious diseases, primarily HIV and hepatitis C, but also as well as endocarditis. Been an upsurge in endocarditis with injection drug use. And so we identified 9 barriers to treatment, starting with prior authorizations for some of the 3 medications that we use for treatment of opioid use disorder, primarily buprenorphine, but also stigma. We address the fact that we have data separation because of CFR 42 Part 2, the fact that we can't mix our medical records or information because of privacy. We have payment problems, and of course we have problems with the criminal justice system in the fact that in most instances, when patients are in the criminal justice system, they're not provided any of the 3 medications that treat this disease. It's unheard of to take that approach. And patients were actually taken off of medications when they were incarcerated. So this is Dr. Josiah Rich in Rhode Island, who published a seminal study in 2018 where they instituted buprenorphine in the jails in Rhode Island and showed a dramatic 60% decrease in overdose deaths upon discharge. And we know that from a study in the state of Washington some 15 years ago that the first 2 weeks post-discharge really represent the highest rate of overdose deaths among patients. So that having a patient started on medication can save their life upon discharge. The same thing with the emergency room study that Dr. Compton pointed out from Yale. We now know they're starting buprenorphine, methadone, in an emergency room setting post-overdose is critical. So this simply really summarizes our problem when we talk about structural incompetence creating a problem. And I can't think of a statement that better encapsulates that concept. So we as physicians, and this is a statement by from Howard University, from Howard Houston, who really was the mentor for Thurgood Marshall in Brown versus the Board of Education. And we now know that Charles Hamilton Houston, that we as physicians or medical providers have to apply the same concept. So our goal is to reverse engineer the incarceration or the industrial prison industrial complex and the incarceration for treatment model. And there is a model called law enforcement assisted diversion or LAD, in which patients, instead of being taken to jail, are taken directly to treatment. So when we organized my practice or reorganized my practice back in 2013 to address this problem, I was invited back to Howard University to the Department of Behavioral Health and Psychiatry. I'm an internist, and my question was, I can't, why are you inviting me back? The idea was to merge mental health, substance abuse, and primary care in the same setting. and to remove the siloed approach. So we developed a team-based medical treatment model. We also realized that we needed a community-based model. And so we met with local pastors and formed a group called the Leadership Council for Healthy Communities. And this is a picture that actually shows psychiatrists, internists, pastors at a church discussing the mental health and substance abuse problem in our metropolitan area. So when we put those two together, we present a model that really addresses the issues that we have here in the District of Columbia. So the arrows that you see in these panels point to the location of my office. On the left-hand side, you can see the impact of the opioid epidemic. The more color you see, green, red, yellow, or blue, indicate opioid overdose deaths. In the middle panel, homicides, and on the right-hand side, HIV and hepatitis C. So this is a picture that actually in the parking lot of my medical building. And this is every day, 24/7. And these are pictures from the front of my office on the upper left-hand side 2 years ago with an overdose. Bottom panel, again, showing a drug-related murder scene. The upper right-hand side, actually last Friday, we had an overdose in the office. Again, one of my regular patients who had gotten something before he came in the office. And that patient actually, it took 6 Narcans to resuscitate him. So this is a profile of my patient population. We currently have 210 patients, but then we had about 270. You can see the breakdown. We have an older population. And this is the siloed impact that we're trying to change.
Dr. Chapman, yes. I'm so sorry to interrupt. We are running late on time, so we are going to have to transition to our next speaker. If you'd like to just close out quickly, and then we can always come back to some of this during our Q&A session.
All right. In closing, I would really point out the fact that we generally have to use higher doses of buprenorphine, higher doses of Narcan. We have a very high homeless rate, so housing is a critical issue. Of course, we depend heavily upon having concept of really bringing in needle exchange, educational literature, fentanyl test strips, Narcan, and referrals for MOUD, primarily harm reduction as a standard of care. These are just some of my patients who've been successfully treated. We know that this saves money and saves lives.
Great. Thank you so much, Dr. Chapman. And we'll make sure your slides are available on the website so people can click through them afterwards as well.